the opportunity to coming over to Ireland and talking about the lessons learned from mid-staffs, and I think you're hoping to spread some of what we found, what we encountered when we arrived, and hopefully a little bit of what we've done to start to put things right. And I think when you hear from Colin and Manjit later on, you'll understand it's a continuing journey. None of us are going to stand here and say it's right, we're there, it's finished. But hopefully the direction of travel is positive, and there are some good things now happening in mid-staffs to give people confidence back in the healthcare system within that environment. Talked about my background. I mean, the one important bit in there is just the dates around mid-staffs, bearing in mind a lot of the criticism was about money out in mid-staffs. I just want to make the point that I arrived in July 2008, which was after the event, and was the first of the new board, which was an interesting time because clearly at that point there was 10 other people around the board table who were perceived to be part of the problem. And there's a lot of denial, a lot of aggression, etc. around that board table, and it was interesting times about how they reacted to all the criticisms and the Healthcare Commission report. And looking back, as ever when you leave these things, it's good experience. At the time, there were some really difficult times to go through. Equally, by the time I left in April 2010, I was the longest serving board member, less than 2 years later. Probably not a huge surprise really to most people in the room, bearing in mind what had gone on at mid-staffs. My presentation this morning is really a little bit around the history, and it is important to talk a bit more about the history because I think there are some important lessons about some of the governance and some of the assurance that was going on in the system at mid-staffs at the time. So the history actually is an important point. So I make no apologies for dwelling on that to some degree. Obviously Colin and Manjit will talk more about the here and now. My purpose is more around kind of the history, the findings, and some of the initial governance learnings, and my presentation very much centres on governance. I'll leave the medical and the nursing stuff to Colin and Manjit. So in terms of the history of mid-staffs, in 2005 the NHS was in deficit position. The provider side, clearly we had commissioner and provider split, so the provider side was about £0.6 billion in deficit, and there's very much a kind of central edict about sort the money out. And you may recognise some of that edict yourselves now. It's very much focus on the money, get the money right, get back to break even or surplus. And there's a kind of a brackets at all costs almost. And at that point there was very immature and very naive systems and processes around quality. And quite frankly, we just did not monitor quality to any great degree at the top of the shop in an organisation. The focus was very much around kind of money orientated things. So there was a board replacement programme in the year 2005-06 mid-staffs, and new chair, new chief exec brought in with a very clear remit that the organisation's in deficit, you're going in to sort it out. And over the time they replaced the whole board over the years of 2005 to 2007. It's fair to say there was limited clinical engagement, and I'm sure both Manjit and Colin will go into more detail about that. But I think there was extremely limited clinical engagement throughout the organisation. The board, top of the organisation, really did not understand or know what was going on at a ward level. There was a very kind of clear disconnect through the organisation. The inquiry and the Healthcare Commission very much focused on the 10 million out in 2006 as the start of the problems, or they perceived that to be the start of the problems around the kind of quality of care issues starting to emanate in mid-staffs. One of the biggest cost improvement programmes at that point was this thing called the Nurse Floor Programme, which was designed to take away the identities of individual wards and have 2 floors of medicine and 1 floor of surgery, and have more generic nursing that would just transfer across the floor and be able to flow much more easily in terms of covering shifts, covering vacancies, absences, etc. Clearly what that also meant is we could dilute the skill mix, have much more healthcare assistants, etc. So it was a money-making scheme, or cost-saving scheme. It was an American model. The director of nursing at that time had been over to America, had seen this in operation, was personally completely signed up to it, and convinced the board that this was the right thing to do as part of the cost improvement programme and taking the £10 million out. It's probably fair to say the board didn't offer a huge challenge at this point, possibly because they were fixated by the pound signs attached to that programme, and certainly did not seek any external verification or triangulation of that method and whether it worked and what would be the impact of quality. So they weren't asking the right questions, they weren't seeking the right assurance, they kind of took the kind of golden goose as that's a large proportion of our cost savings programmes, so yes, we'll do it. And we had the Director of Nursing personally saying at board this was the right thing to do and it wouldn't impact on quality. So we took the nurse staff reductions out and the skill mix, and we ended up roughly with a skill mix of 40-60 in terms of trained and untrained nursing staff across most of the wards. Clear that differentiating in some of the more specialist wards, but generally we're looking at 40-60 skill mix. After 2006, the organisation started to stabilise financially and started to have an improved financial performance and started to deliver small surpluses. Equally, and we'll go into a bit more detail in the next couple of slides, but there was increasingly positive external assurance, and the board placed a lot of adherence to that external assurance. So we were delivering on the numbers, so we, the trust at that time, were delivering it financially, and there was increasing positive noise from external regulators saying actually, not only have you sorted the money out, but the quality of care actually is improving. So as a board, they were getting all the right messages, seemingly at that point, really. Then the Dr. Foster Mortality League Table was published in April 2007, which took the organisation by surprise. It shouldn't have done, because it had been published years before. Every month the information was there, but the board had not been seeing it. The board was blind to it, and it had not been reported to the board. So when it came out, they were fifth bottom nationally. It was a huge surprise to the board and ran contrary to all the other external assurance they were receiving at the time, which clearly stated that quality was improving. There was also a local pressure group called Cure the NHS, which many people will have no doubt heard about, that was formed. A lady called Julie Bailey, who was a relative of a deceased patient at the hospital, and the organisation dismissed her as a relative of a deceased patient who has not got closure and will never get closure, irrespective of what we say or do to it. So we dismissed her and pushed it to one side. She formed a group which became increasingly powerful, increasingly astute, very well connected politically, and she certainly helped drive through the profile of mid-staffs and probably helped bring the Healthcare Commission in reality, in 2008. So there's something about how we deal with complaints with what's perceived to be problem relatives, problem patients. The organisation then received FT or Foundation Trust Authorisation on 1st of March 2008. Again, positive assurance. Another new regulator is saying we're fit for purpose. We're clearly, we've gone from being in deficit, now we're a good quality Foundation Trust. It was a real good kite mark at the time in early 2008, and Mid-Staffs is one of the first district general hospitals to achieve Foundation Trust status. So again, it's perceived to be one of the best DGHs in the country, according to the regulator. And then 5 days later, the Healthcare Commission announced they were going to conduct their investigation on the back of the mortality statistics. So no apology for dwelling a little bit on the history. I think it's important to set that scene, really, of that broken organisation and then starting perceptionally to improve. Quick counter through some of the nursing. Colin will certainly go into more detail about the here and now and the present, but certainly when I arrived, what was relevant, what was obvious, was a committed but stagnant nursing workforce. Very little turnover. When I started on day one, people wore their years of service like a badge of honour, and everybody I was introduced to on day one was very much to say, hi, I'm Mary, I've been here 22 years, I'm Joan, I've been here 25 years, and it really was a badge of honour about how long people had been at Mid-Staffs as a positive. The corollary to that is there was not a lot of new blood and new ideas coming into the organisation, and there's kind of institutionalised behaviour because we had a static workforce. Because of the previous financial problems, there was limited access to learning and development, with very little in-service kind of professional and practice development. It's one of the first things you cut, isn't it? times are hard, you cut the training and development, you stop those kind of discretionary activities. Clearly, a number of years down the line, that has to have an impact on quality. And we had nurses that couldn't operate equipment on wards, etc., because even the kind of basic in-service things had been stopped. And it was all hands to the pump, because we'd really slimmed down the nurse establishment. So there was no ability to take time out for training and development. There were very few clinical leaders. We'd stripped them out because of the financial position, so we took out a kind of layer of senior nurses. So again, that helped create that disconnect and that gap between the ward and the board as part of the cost-saving processes. And there's a very hierarchical approach to nursing there as well. So there are very few senior leaders and very kind of vertical lines, really. So in summation, there's a limited nursing voice in the organisation. With a relatively strong and charismatic director of nursing as well, who's telling the board, this will work. I've seen it, I believe in it, trust me. And there was very little opportunity for other people to have that input from a kind of professional nursing point of view. So we'll go back to the external assurance and the increasing or improving external assurance for what it's worth. Healthcare Commission itself in 2005-06 said the organisation was poor. 2 years later, it was good. So in 2007-08, the Healthcare Commission itself said it was providing good quality care. And that was the same year it announced its visit, and the same year that the Dr. Foster mortality figures came out. The clinical negligence scheme for trusts, kind of the self-insurance pooling arrangements within the NHS. In 2007, the organisation was rated level 3 for general healthcare and level 2 for maternity care. The top level being level 3. And very few trusts had maternity level 3. So actually a 3 and a 2 was pretty much as good as it got for the vast majority of trusts. And there were many trusts below a score of 3 and 2.